the fact is, I remember back in March when we first began to cover the spread and asking hospitalists and emergency medicine docs what their greatest concern was as they knew cases were going to begin to spike. And they didn't discuss personnel. Personnel was an easy strategy that was resolved in terms of allocation of maybe elective course physicians or any other caregivers that could provide emergent care. It had to do strictly with the resources. And that's in areas of the world and in our nation, especially, where you would think that would be the last thing that would be on their mind. This is, top level institutions, and hearing that the PPE matter was one that was not resolved cleanly. And I remember a lot of issues about just the amount of funding going into assuring in hindsight that we had enough PPE was deeply troubling. And it shows that it's actually highly prevalent. It's not just a rare circumstance. It wasn't something that we were well prepared for. Can we talk a little bit about that preparedness and what factors may have played into that prior to all this?
Yeah, I think the whole crisis and the speed of the pandemic, I think, really laid bare a lot of underlying problems that I don't think anybody really truly acknowledged. I think one of them was the supply chain for protective equipment is deeply fragmented across the country. I think different parts of the country have different levels of access, different quality PPE, and also different policies with respect to dispersal. So the fact that there wasn't any kind of national or centralized approach to handling how PPE was going to be resourced across the country was really a major problem, especially when you're dealing with a large-scale health crisis. So the fact that this was so fragmented and the response was fragmented, I think really put us behind the eight ball when it came to responding in a cohesive way. And it was pretty clear at the outset there were some areas of the country that were maybe even overstocked with PPE, whereas there were other areas of the country where there was really insufficient levels. And it was a clear mismatch between need and supply. And that, I think, was something that really was quite eye-opening. And, I think it gets to also, broader questions about resource allocation in other domains of healthcare, including, pieces of equipment that are needed to help care for patients, physician supply, nursing supply. So those are all things that I think really became quite evident through the crisis. And I think, again, was something that maybe we had some sense of before, but I think the pandemic really made it very clear and underscored those differences. And I think that's really why we embarked on this study, was I think we wanted to take one piece of that and really show with hard numbers that this was a problem.
And what sort of response have we had after the fact? Obviously, your team's findings really, emphasize and amplify that issue, as it's not anecdotal. This is something almost globally is a major matter. If it was affecting the U.S. and U.K., you can guarantee it was affecting other regions that were greatly burdened by this. The matter of resourcing being highly valuable in, emergent preparedness. How does that affect us now when we're in a spot where cases, I saw just this morning in India, over 55,000 new cases in a day. Whether you want to call it the first wave or second wave, as a new beginning, obviously cases are spiking still, and this is still a matter we need to address. Is there any way that we can handle this proactively now that we're sort of out of that first reactive stage?
It's a great question. I think the inequities are still there, and I think the PPE problem is obviously still there, and we've seen those reports across this country and continues to be an issue in the regions of the U.S. where there continue to be large-scale outbreaks. And as you mentioned, there's clearly going to be issues and are issues across the globe in terms of addressing these kinds of shortages, particularly in more resource-limited settings. So, we're going to be in this for a while, and I think this leads people to, I hope, think hard about trying to understand the supply chain for PPE, understand also what are the sort of rules and regulations that sort of govern its dispersal and allocation. And I think that with that type of thought process and thinking process, we hopefully will come up with more broad-based solutions that could be applied to, at least regions of the country in a more uniform way. I think we are seeing some evidence of that potentially happening. And I think there have been, in addition to our paper, additional reports out there about how during the early phase of the pandemic, there was really a huge mismatch in sort of dispersal of PPE. So I think with enough of those types of stories coming out and enough data coming out, I think policymakers will, and healthcare planners will hopefully really take notice. And I think when it comes down to the local level, I think, specific hospitals and healthcare systems are, I think, aware of their own limitations with respect to PPE, and I think are really becoming more vocal and advocating for PPE to be allocated to them in an effective and efficient way, and do so in a way that's a little bit more anticipatory with respect to their needs for the future. So I hope that this will alleviate some of what we saw in the early phase of the pandemic. But, I think it still is an open question, because there are still probably deep-seated inequities that are beyond just simple PPE policy. I think, in particular, the evidence that Black, Asian, and ethnic minority healthcare workers are differentially affected reflects not just PPE access, but also that they work in different care settings, and some of those care settings may be higher risk care settings that are a reflection of the type of jobs they get, the type of neighborhoods they live in. And so those are things that won't change quickly and won't change because of the centralized PPE policy. We also are understanding more and more that healthcare workers from those backgrounds are facing not only a higher occupational risk, but also potentially higher personal risk from being in communities where there's larger scale outbreaks of COVID, where also they may be in living conditions which are not conducive to social distancing. We know, for example, a lot of healthcare workers from those backgrounds live in multi-generational housing, live in areas of the country that are more densely populated, need to access public transportation more. So all those factors are structural that are not going to be eliminated overnight by healthcare planners. It's going to have to become, I think, from a more structural look at how minority healthcare workers are dispersed across the community and where they're working. And those, again, I think have to do more with deeper issues of structural racism than they do with just healthcare allocation.